Good morning and welcome to everybody to this lunch session. Thermo Fisher support this lunch session. And this is a lunch session on a very relevant topics in clinical practice. Unspecific symptoms of infection in the elderly. Are antibiotics always necessary? This is clear that is a multidisciplinary topic. And indeed, the speakers in this symposium session derive from different specialties. So we have excellent speakers from the intensivist area, specialists in infectious disease and the geriatrics with high relevant experience in infectious disease. The first speakers, we can move. Okay. We can move to the next. Professor Marco Falcone. He is professor of infectious disease at the Department of Clinical and Experimental Medicine at the University of Pisa, chair of the study group for infectious disease in the elderly of the European Society of Infectious Disease. Antibiotic exposure in the elderly, why to be careful? Please, Marco.
Thank you, Alberto. Thank you to the organization and to the sponsor for the invitation to this beautiful congress. These are my disclosure. I speak you of a problem that you probably daily face with the management of antimicrobial therapy, especially in geriatrician or the internal medicine or physician that work in the hospital, okay? There are some studies that suggest that during hospitalization of elderly patients, about 1/2 of the patients receive antibiotics or at admission because they are hospitalized for an infectious disease, or during the course of hospitalization because they are affected by nosocomial infection. Then this is very, very important and very important point. And for a lot of organizations, the widespread use of antibiotics and the inappropriate use of antibiotics is a factor that impacts significantly on the spread of multi-drug resistant bacteria in the hospital and also in the community. Which problem is related to the pharmacokinetics and pharmacodynamics of antibiotics in the elderly? You know that pharmacokinetics studies the concentration and the mechanism of elimination of antibiotics. Okay, as you know, the several organs, several systems are affected by the age. Primarily the renal function. You know that during the age you have a progressive deterioration of the renal function, but also other mechanisms of adsorption or elimination are impaired in the elderly, independently from the presence of specific underlying disease, of a specific illness. The second point is that when we consider the appropriateness and the efficacy of an antimicrobial therapy and antibiotic therapy, we usually use some pharmacodynamic parameters, some ratio, for example, the MIC of the microorganism, of the bacteria, and the level of antibiotics that I'm able to reach in the site of infection. Okay, we have some parameters, some ratio that predict the effect of the antibiotic and antimicrobial therapy. Anyway, in the elderly, although you are able to reach a good concentration of antibiotics and the MIC, for example, of the pathogen is good, there are some factors that can cause the failure of antibiotic therapy. Although you are giving the right dose and the right drug, and these are the immunosenescence, okay, a reducing the physical ability to deal with infection. This impacts the response, and also the anomalies and the impairment of several functions, cardiovascular, central nervous system, hematopoietic disease. Then we have to be very careful when we use some antibiotics in general, and specifically some molecules, some drugs that have several important side effects in the elderly. Regarding the old drug, you know that one of the most used antibiotics in the history of antimicrobial therapy has been the class of aminoglycosides. Okay, you know that they are very effective against gram-negative bacilli, especially causing urinary tract infection. But the major problem is the renal failure as the acute kidney injury. This is related with this class of drug. Nowadays, a lot of guidelines suggest not to use as first choice this class of drug, especially in elderly patients that have a minimum impairment of the renal function. This study evaluated the impact of acute kidney injury in elderly patients receiving aminoglycosides. This study was quite well designed because all patients had the detection of serum level of aminoglycosides in the blood. Then the dosage was adjusted according to the appropriate serum level, was not a fixed dosage. And as you see, about 17% of patients develop an acute kidney injury, and the development of acute kidney injury is associated with an increased length of hospital stay and also with increased mortality. Probably these patients that develop acute kidney injury are more severe patients, are septic patients, are patients that have some underlying disease, but you should be very careful when you use this drug. But if we can overcome the use of aminoglycosides, because we have other molecules, for example, colistin for several years has been the only option to treat carbapenem-resistant bacteria, for example, Pseudomonas carbapenem-resistant or Klebsiella pneumonia resistant to carbapenem for several years. Now we have new options, but colistin has been the cornerstone of therapy. Colistin is a drug difficult to use because you have to use high dosage to be effective, and the high dosage are usually toxic. Then it's not easy to balance between the efficacy and the toxicity of this drug. In this meta-analysis, you see that the use of colistin is independently associated with the risk of nephrotoxicity. This risk in elderly patients is double or triple compared to young patients, because in young patients you can do an hyperhydration that reduce the risk of colistin nephrotoxicity, but during the elderly, because the presence of heart failure, you can give fluids, and also this drug is quite difficult. Another interesting example of the management of antimicrobial therapy is linezolid. Linezolid is a drug very effective in pneumonia, is active against methicillin-resistant Staph aureus, is almost one of the most recommended drugs for guidelines for the treatment of some infection caused by MRSA. But you see in this really interesting paper, which is the concentration of linezolid according to the age. For linezolid is recommended at a fixed dosage, 600 milligrams every 12 hours, okay? And there is no, the recommendation in the RCP is not to change dosage independently of the kidney function, okay? Also in patients with hemodialysis, you can use the standard dosage. Anyway, there are a lot of studies that demonstrate that in patients with an advanced age, the fixed dosage is associated with a over therapeutic concentration of linezolid. And the increase of serum concentration of linezolid is the factor that causes the most important side effect, the piastrinopenia or thrombocytopenia, that is the most important cause to discontinuation of linezolid. Then after 70 years, over 80 years old, the risk of the toxicity of linezolid is very high. And interestingly, there is also a sex distribution, because this phenomenon appears to be more common in female compared to male. We don't know exactly how, probably there are some factors related to elimination of the drug, but especially in female, this overexposure of linezolid was associated frequently with side effects of the drug. And then we should be we should decide when to use this drug or not in a good and appropriate way, which is the other face of the medal. The other face, and this is a survey that we conducted with a European Study Group for Infection in the Elderly of the European Society of Clinical Microbiology and Infectious Disease, to evaluate some practice of infectious disease, but also of geriatrician, internal medicine during the COVID first and second so-called pandemic waves. And the vast majority were colleagues working in medical wards, as you see. And which difference are, as you know, there is a different approach, at least during the first wave, second wave, in several hospitals. The approach for elderly with COVID-19 is different compared to middle or young patients, okay? A lot of patients are not candidates, independently from the risk of death, are not candidate to ICU. Some patients are excluded from the use of immunomodulators. This is a survey that reflects the real practice in several European hospitals. But what was really impressive when we conducted this survey is the rate of prescription of antibiotics at the admission of patients with COVID-19 pneumonia. That is a viral infection, it's not a bacterial infection, okay? And then antibiotics theoretically are not indicated, but you can use in some cases, or according to some features, or according to some clinical suspect. But you see that during the first wave, the antibiotics were prescribed in 100% of cases, by the 10% of participants to this survey said that in the 100% of cases they prescribed antibiotics, and the 42%, then the vast majority, prescribed antibiotics in the majority of cases, between the 50 and the 100% of cases. Situation improved during the second wave, but not so significantly. The prescription of antibiotics was very high. It was one of the factors that caused probably an increase of infection by multi-drug resistant microorganisms in the COVID-19 medical and ICU wards. This is a problem that has been recorded in all Europe, also outside Europe. During the pandemic phase, we had more infection caused by multi-drug resistant bacteria, especially in ICU, and probably this antimicrobial antibiotic pressure had a role in predisposing to cell selection of drugs resistant to antibiotics. In this view, we tried with my group of research to understand when it's appropriate or not to start antibiotics in patients that arrive to the hospital with a diagnosis of pneumonia caused by SARS-CoV-2, okay, COVID-19. We hope that during the next month, next future, we will see very few cases, but this is not sure. And then we have to look to the past experience to improve some approach, okay? This is a study that has been performed prospectively in my hospital, and our objective was to identify predictors of respiratory co-infection. When a patient with COVID-19 has also an infection by Streptococcus pneumoniae or Mycoplasma or Staph aureus, okay, a bacterial co-infection, because this is the only rationale to start antibiotics during at admission when a patient arrives, and this is very common. We know that co-infection, look into the literature, co-infection are very rare, less than 10%, in some studies less than 5%, and superinfection, or nosocomial infection after hospitalization are very common, very more common compared to co-infection. That is probably not indicated to start antibiotics at admission, but it's very important to look to the secondary complication by, especially if the patient remain for a long time hospitalized in ICU, caused by multi-drug resistant bacteria. Okay, what we did in 547 patients with COVID admitted to the hospital. You see that the median age was 74, median age was about 72. Then the vast majority of the patients were older patients. And we were able to make diagnosis of respiratory infection in the 8% of the case. 8% is not a little number, okay? I had the idea that were less. Anyway, there is about 8-10% of patients can have a co-infection, a bacterial co-infection. Then in this case, you have to start antibiotics because the risk is that the patients progress to respiratory failure caused by the bacterial co-infection and not by the COVID-19 itself. You see that patients that have a respiratory co-infection usually have a Charlson index higher, then usually have more comorbidities. Very important is the presence of sputum, okay? Sputum, purulent sputum is anything that should be considered when to start or not antibiotics. Patients of their relatives says that the patient had sputum, purulent sputum, probably there is a risk of a bacterial co-infection. Usually this patient had a worse, increased severity of the respiratory impairment. You see that there is an PCT increase. I will speak about the PCT increase, and the 30-day mortality is quite different, okay? 30% in patients with co-infection and about 8.8% in patients without respiratory co-infection. Then this data seems to suggest that the presence of respiratory co-infection at the time of diagnosis impacts negatively with the outcome of COVID-19 pneumonia. Which are the bacteria that are most commonly associated with this complication? Streptococcus pneumonia is the most common one, and followed by Mycoplasma, Staph aureus, other ones, but the vast majority were Streptococcus pneumonia infection. This is very important to reinforce the need of vaccination against Streptococcus pneumonia in elderly patients at risk of hospitalization for COVID-19. When we evaluated at multivariate analysis the factors independently associated with this respiratory bacterial co-infection, there was the severity of respiratory impairment calculated as PO2-VO2 ratio, okay, less than 200 is a parameter. The presence of sputum on admission, and from my point of view, quite important for clinician, an increase of PCT, not a decrease, an increase of PCT during the first 72 hours. Then PCT is a marker that at the admission, single determination, there was no difference in patients with or without bacterial co-infection, but if you, within 24, 48 hours, repeat PCT, you note an increase. This is a very significant parameter to hypothesize the bacterial co-infection and to start antibiotics. In this case, you have to start antibiotics because the co-infection is associated with a significant increase in the rate or in the mortality rate. And then Charlson comorbidity index. As you know, patients with more comorbidity, with more frail, with more advanced disease, for sure, have a higher risk of mortality. My last two slides, I try to remain in time, are related to another side effect of antibiotics when they are unnecessary. Okay, if you have a bacterial co-infection, pneumococcal pneumonia, and COVID-19, for sure they are appropriate, is the selection of species in our microbiome that are potentially dangerous. Okay, this is a study very interesting because they evaluated the effect of some common antibiotics, penicillin, macrolides, in a 4-day regimen of antibiotics on the gut microbiota. And as you see, there are some species of our microbiota that survive to the effect of antibiotics. Bacterium, some species survive, remain at the same level of previous of antibiotics, or there is a fast recovery of this bacterial population. Some patients, some strains are de novo colonizers, okay? Some Clostridiaceae, in particular species of Clostridium, are de novo colonizers after they start just 4 days of antibiotic therapy. Some species, very important to maintain a good homeostasis at the level of the gut, as bifidobacteria and other disappear, and this is the major dangerous effect of antibiotics, you see. But from another point of view, there are opportunistic bacteria that are Klebsiella, you see, Enterococcus, but particular gram-negative bacteria, gram-negative bacilli that colonize the gut and subsequently can spread to the blood, and the colonization by, for example, KPC Klebsiella or ESBL producing Klebsiella pneumoniae is a risk factor for subsequent bacteremia, for subsequent urinary tract infection, and this is there is a major role of the previous antibiotic therapy. Elderly diseases, these are probably studies that you know very well because are some Aran and other colleagues that study a lot the microbiome in the aging, aged patients, elderly patients, independently from antibiotics, independently from the underlying disease, but also in relation to the polytherapy and a lot of drugs that they take have an affection of the composition of the microbiome, already related to the age. If in these circumstances we also give a pressure that promotes the selection of some bacteria species with the use of antibiotics, there is a great risk. Then we have to use these drugs with judgment. This is the most important thing, to use antibiotics only where is needed, and using, if possible, all the tools, diagnostic tools. They can be radiology, but there can be also laboratory markers. For example, Procalcitonin is quite useful to decide or not if there is a bacterial infection, and you can use it when you decide to start, and you can use it also when to decide to stop, because in few days a bacterial infection usually resolves if the patient has a good immunity system, and then you, after 5 days, 7 days, can stop antibiotics. A PCT can be useful to decide if for early discontinuation and antibiotics. It's important that antimicrobial stewardship is a term that is not easy to translate, is a good use of antibiotics. Anyway, this good use of antibiotics is that my last consideration should be accompanied by strict procedures of infection control, because the infection that we treat, the nosocomial infection, frequently are related not only to the use, the widespread use of antibiotics, but also to the lack of some hygiene and infection control procedures. And thank you very much.
Thank you, Professor Falcone. We have time for some questions from the audience. You introduced perfectly the next speaker as a topic in the use of inflammatory markers, but you launched some very important messages. Some comments or questions? I have a question for you. Do you have some functional or cognitive or nutritional information in a frame of a multidimensional, comprehensive approach to the older patient with co-infection compared with patient without co-infection? It should be interesting because the length of stay is quite different, the mortality is quite different, the comorbidity is different, most probably the mean age is quite different. And the functional status?
Yeah, I think that functional status play probably the most important role also in justifying the data of outcome, increased outcome. And this is what we have to probably implement more in the emergency department, for example, also in ICU, an evaluation of the functional status that is not ever done in the acute phase of a diagnosis of infection. I think that our relationship with you, with geriatrician, infectious disease, ICU are three categories that should speak a lot, because also the best approach for treating these patients is not clear, is not ever clear, and probably the assessment of the functional capacity and the risk of death is very important also to decide when to allocate these patients to an aggressive procedures or aggressive therapy and when to de-escalate therapy. We performed a study with our group, and we found that the functional capacity, the inability, physical inability was one of the major factors, most important factor that predict mortality. Not sophisticated parameter, a scale not so sophisticated, but I think that we have to study more with the multidimensional assessment of the functional capacity of this case.
Thank you. Okay, we can, thank you, Professor Falcone. We can move to the next. The next speaker is not here in presence, but he is here virtually. Welcome to Professor Evangelos Giamarellos Bourbulis. He is online connected from Athens. Hello, welcome. Can you hear me? Okay.
Thank you very much for the elegant presentation, and thank you also to the team of Thermo Fisher for inviting me. Just a small second, I have a problem in changing my slides, which I tried to solve.
Okay, so Evangelos, let me introduce your persons, because here is a geriatric audience, and Evangelos Giamarellos Bourbulis is a specialist in internal medicine, infectious disease, and is an intensivist, expert in immunomodulation in sepsis. He received also an Investigator Research Award by the European Society of Clinical Microbiology and Infectious Disease. Currently, he is professor of internal medicine at the medical school at the National and Kapodistrian University of Athens in Greece. So, if your slides are ready, we are ready to follow your talk on the benefits of PCT, Procalcitonin-aided antibiotic stewardship. This topic has been introduced also by Professor Falcone in previous talk. Please, Evangelos.
Thank you very much. Thank you for the elegant presentation. I, at least here in my screen, the presentation is moving, so I would like to confirm whether this is happening. Here is my conflict of interest disclosure, and allow me to start with the problem, which is the main problem that has already been introduced by Professor Falcone. A patient is doing better. He's not doing worse after a few days on antibiotics. And then, as we are at bedside, we are asking ourselves, shall I stop antibiotics? And how about if he gets undertreated? And how about if he relapses? And allow me to tell you, you said already that your conference is focused on geriatrics, but the main task that we are following, at least in the general ward, in our internal medicine ward, is that the majority of and of hospitalized patients are not just elderly, but they are, someone would even say that they belong to what is now considered to be the fifth age. So all of a sudden, they cannot develop in an easy way the clinical signs of younger patients so as to instruct us how we can deal with this problem. So one idea is, instead of continuing antibiotics because we are afraid to stop them, let's try to make a readout of the reaction of the host to treatment. In other terms, to use a biomarker that can guide us when is the appropriate time to start or to stop an antibiotic. So look what we should do. We need to incorporate a biomarker in the algorithm of decision making. In other terms, the biomarker needs to guide the need to start antibiotics, the time to stop antibiotics, and also it needs to be adapted to underlying severity, to the settings of the patient and the comorbidities. With this in mind, there are several features the biomarker has to do. And as a matter of fact, you understand with this approach that we are entering more and more to what is called precision medicine. And the FDA in 2018 has launched a demand where, in order to use biomarkers or in order to use a device for decision making, what is needed is not to do a study and then retrospectively measure the biomarkers in the collected samples of the patient, but do a prospective study where the measures of the biomarkers or the interventions in the patients are decided prospectively, pre-hoc, by the biomarkers. So we want that this approach does not introduce harm. We want that it provides clinical efficacy, and we want that it's validated through randomized clinical trials in exactly the way the demands of the FDA are placed. Allow me to show you an example. This is an algorithm for start of antibiotics in intensive care unit. It's a randomized clinical trial where patients are subject to start of antibiotics upon a decision of the physicians, which is guided by the levels of procalcitonin. So if procalcitonin is less than 0.25, the start of antibiotics is discouraged. If it's between 0.25 and 0.5, it's discouraged more or less. It's more than 0.1, it is encouraged. However, someone may say, okay, just one measurement. It may be the case that the biomarker, and in this situation, procalcitonin may all of a sudden change. So repeat the measurement after 6 to 12 hours. And if this is the case, then follow the algorithm. However, we need another algorithm to stop antibiotics. And the algorithm tells, we start measurements after a few days, practically after 3 or 4 days. And when we realize that procalcitonin is less than 0.25, it's strongly encouraged to stop antibiotics. When we see that the levels of procalcitonin are below 0.25 to 0.5, or they have increased to more than 80% by baseline, and allow me here to open a parenthesis. Yes, I know very well that a procalcitonin, for instance, of 2 or 5, as a value is considered increased, but if the baseline is 50 and it goes down to 5, that means that you have a spectacular decrease, and in that situation, you don't trust the absolute number, but you trust the decrease. But if you see that your procalcitonin is increased to above 0.5, then you have to change antibiotics. So this is the seminal proof in the ICU. These are the curves to stop of antibiotics. In blue is the control group. In other terms, physicians were stopping or starting antibiotics as usual. In blue is the procalcitonin group. So physicians were guided to start antibiotics and to stop antibiotics according to the algorithm that I told you. And you see that there is a spectacular earlier stop of antibiotics And actually, the relative reduction of exposure is 23%. But the most important is that through this approach, the patient's life are not at risk. The mortality between the two groups does not differ. So, what a procalcitonin stop-it rule means according to the type of patient, the comorbidities, and the settings. So you get a decision to treat. And after a few days, practically on day 5 or 6, you start measuring procalcitonin. And when you reach this point, the point red that I point here, you compare your procalcitonin to the baseline measurement. And based on this, there are 3 main algorithms which so far have been tested. The first, to stop antibiotics, when after certain days we figure out a decrease of more than 90% from baseline, or when procalcitonin was below 0.1, we have 2 randomized clinical trials for that. Another criterion which has been tested in 3 randomized clinical trials is when you see a drop of more than 80%, or you see that procalcitonin is below 0.5, and another 2 randomized clinical trials tested a more than 90% decrease or a value less than 0.5. Here are these trials, these 7 trials, and all of them have the same denominator: a significant decrease of the time to stop of antibiotics. None of these trials has mortality as an endpoint. And as you see, more or less, the number of patients in these trials were rather low, and it's difficult to have as an endpoint mortality. So let's put all these trials together. And this is a meta-analysis of 11 studies published with more or less a similar design. In these studies, we have 2,230 patients in what we call standard of care. And standard of care in these type of trials means that the patients are subject to stop of antibiotics as usual. And we have the procalcitonin arm, where physicians decide to guide themselves by procalcitonin for the right time to stop antibiotic problems. And you see there that we have cumulatively 2,252 patients in these trials. No doubt, the days on antibiotics are significantly decreased, but all of a sudden, when you have so many patients together and you have such a power, you have a significant decrease of 30-day mortality. There is, however, one trial which has enrolled far many patients than the other trials, which, as you may see, have enrolled less than 70 to 50 patients per hour. It is the SUBS-trial, a multicenter study in 15 study sites in the Netherlands, with all types of severe infections. Antibiotics are stopped according to the guidance of procalcitonin, and the stopping rule is that antibiotics are stopped after daily measurement of procalcitonin on the day when procalcitonin has decreased by more or at least 80% from baseline, or procalcitonin is found less than 0.5 nanogram per ml. 1,575 patients are randomized, 785 in the standard of care arm, 761 in the procalcitonin arm. There is no doubt, there is no reason to point the primary endpoint. Yes, indeed, procalcitonin managed to decrease the time to stop of antibiotics, but with such a power, one of the main secondary endpoints of this study, which is mortality, mortality by day 25, mortality by 1 year, goes significantly down when you use the procalcitonin rule. And as it is anticipated, with less antibiotics, the patient, the cost of hospitalization drops down. However, although this study was spectacular, and that's the reason why it was published at Lancet Infectious Diseases, there is one element which is missing. So, decrease of the course of antibiotics is of benefit for the patient. The decrease of the course of antibiotics may be achieved by the use of procalcitonin. But the question is, what is the real benefit in terms of mechanism for the patient which is coming to that? So allow me to introduce to our randomized clinical trial, the acronym is PROGRESS, aiming on the impact on gut colonization and long-term antibiotic outcomes. It was published in the Blue Journal, which is the top critical care journal, in January 21. Allow me to acquaint you a bit with the study design. Patients with lung infections, urinary tract infections, or bacteremias are enrolled. And they are randomized into two groups. In blue is the group of stop of antimicrobials at the discretion of the attending physicians. The other group are patients who, after on the fifth day, are subject to venipuncture for measurement of procalcitonin. And if procalcitonin has dropped by 80% or more, or procalcitonin is found less than 0.5, then we stop antibiotics. If this rule is not met, then measurements are repeated after 24 hours, 48 hours, 72 hours, and antibiotics are stopped on the day when this rule is met. Patients are under a very intense follow-up daily up hospital discharge, but also the primary endpoint is not judged on day 28. It is judged after 6 months, and also in order to provide a mechanistic proof about a benefit coming from this procalcitonin guidance rule, we collected stool in order to analyze them for colonization by multi-drug resistant bacteria and also by Clostridium. This is the study chart. 266 patients were randomized. 131 are analyzed in the standard of care arm. 125 are analyzed in the procalcitonin group. Analysis is done according to the ITT principle. Allow me to you a bit with the characteristics of the patients, and I am certain that you will feel satisfied that indeed the results coming from this trial, they apply to geriatric populations. Why? Because you see that the mean age was 78 years in the standard of care group, 79.5 years in the procalcitonin group. The patients, of course, they had significant comorbidities. Mean Cholson score is 6 and 5.6 respectively, where the SOFA score is more than 4, which means that the patients were already on sepsis. Something else that I would like to comment. The empirical administration of antibiotics in these patients was in conformity to the guidelines by our society, our European Society of Clinical Microbiology and Infectious Diseases, in the vast majority of the patients, and there were no differences between the two groups. So we have a primary composite endpoint, which is actually the deleterious effects of antibiotics after 6 months, and how can we manage to decrease them if we manage to shorten the course of antibiotic treatment by using procalcitonin. And this composite endpoint is taking into consideration 3 deleterious effects of antibiotics. First, Clostridioides difficile infection. Second, infection by multi-drug resistant organism. Third, death either from baseline infection by MDR and Clostridioides or long-term. This is the time to the event. And all of a sudden, you see that there is a significant protective effect from procalcitonin guidance. The deleterious effects of antimicrobials, their incidence is more than 50%, and it goes spectacularly down. There is a significant relative decrease by 55%. And then the question comes, is this primary endpoint driven by fecal colonization? The answer is yes. These are the odds ratios to develop the primary endpoint in blue if you are allocated to the standard of care arm. And you see that in both day 7 and day 28 patients who are developing this primary endpoint, they are more colonized by multi-drug resistant bacterial Procalcitonin difficile. But you see that the odds ratio and confidence interval bar of this meta-analysis is crossing the vertical axis. It fails to be statistically significant among patients in whom guidance of stop of antibiotics is driven by procalcitonin. There is no doubt you have lower antibiotic exposure. This is in conformity to all previous trials. These are the curves to stop of antibiotics. In red is the curve of the procalcitonin group. In blue is the curve of the standard of care group. The red curve is moved up to the left, which means an earlier stop of antibiotics. But the question comes, what are the other deleterious effects of antibiotics? Because this is a trial. And since it is a trial, we need to capture all treatment emergent adverse events, both severe and non-severe, for these 6 months. And look what we captured. We captured antibiotic-associated diarrhea, antibiotic-associated acute kidney injury, and other non-serious organ-threatening adverse events like electrolyte derangements, elevated liver function tests, and arrhythmias. In blue is the standard of care group, in red is the procalcitonin group, and you see spectacularly that the odds of having a treatment-emergent antibiotic-associated effect is significantly down for all the 3 types of adverse events. One major key secondary endpoint was mortality. In the standard of care group after 28 days, this is 28.2%. It goes significantly down to 15.2% in the procalcitonin group. And here you see the survival curves. The relative benefit in mortality is a relative 54% increase. So, less adverse events, no doubt, less mortality, and less antibiotics. That means earlier discharge from hospital. These are the curves to hospital discharge. Again, in red, the procalcitonin group, in blue, the standard of care. Again, similar curves to what I showed you earlier for the time to start of antibiotics. And again, a relative 28% benefit towards earlier hospital discharge. As it is anticipated, the overall cost for the health system goes down. And what are the main elements for achieving so? The decrease of the cost of anti-infectives and the increase of the cost of the other drugs. And what other drugs are meant through this approach? All the drugs which are needed in order to cure the treatment emergent adverse events. So allow me to conclude that indeed by using procalcitonin, we can achieve early stop of antibiotics. And what should be, in my point of view and according to our findings and to the most common algorithms which have been studied this testing rule, we stop antibiotics in a patient with infection, lung infection, urinary tract infection, bacteremia, when PCT decreases by at least 80% from baseline or when we find PCT below 0.5 nanogram per ml. No doubt, there is no harm for the patient. On the contrary, we have mortality benefit, and there is shorter duration of antibiotic treatment. In our trial, our progress trial, we managed also to show that this gain in the time to stop of antibiotics, which is achieved by the use of procalcitonin, decreases dramatically, or infection or antibiotic, as you wish, associated adverse events after 6 months. And we managed to provide mechanistic evidence that through this approach, we managed to decrease the incidence of colonization of the gut by multi-drug resistant organisms like Procalcitonin difficile. And this leads to decrease of mortality, decrease of the time to stop of antibiotics, decrease of the cost of hospitalization, and decrease of the length of hospital stay. With this, I would like to thank you very much, and I'm open to any discussion.
Thank you, Professor Zamarellos. Are there some questions from the audience? This excellent presentation. I received by this tablet a question from the audience by Andrew Watson. Did your costing presented include the cost of performing procalcitonin level?
Thank you very much for this question. Yes, indeed, we have adjusted the cost of measurement of procalcitonin, and this has been subtracted.
Thank you. I have a question for you. I saw that you study old patients, include a patient almost with 80 years old. Did you observe some difference in bio availability in serum concentration in the time of decreasing of the procalcitonin during the study, during the period of the infection?
Thank you very much for this question. As a matter of fact, that was one of the concerns of the reviewers when we submitted our manuscript for publication at the Blue Journal. So their suggestions at that point was to repeat a Cox regression analysis introducing age as a continuous variable in order to adjust if there are specific quartiles of age or age limits which where we could see that the benefit of procalcitonin was not apparent. Actually, we were very glad to see that the benefit of procalcitonin applied for all ages. So for all patients, according to our findings, irrespective of the age, yes, the procalcitonin rule should apply.
Okay. And the chronic function and the renal function of chronic disease, for example, may influence the accuracy in terms of sensitivity and specificity?
Well, to be honest, I'm always listening every day when I'm doing rounds with my patients and with my fellows that we should not really trust all those propeptides when creatinine clearance is increased. I've never seen any publication pointing that. There is, this is coming actually from the use of pro-BNP from cardiology. But this is completely different than the acute patient. Here is a patient who's acutely ill. The kinetics to increase are very rapid. The kinetics to decrease is also very rapid. And also what I want to remind is that the change of creatinine clearance in an acute setting is something which is much more unstable than in a chronic setting.
Thank you very much, Evangelos, for your excellent presentation and also for your very opportunity to have a great experience by you. Thank you. And we can move. We can move to the next speaker. It's a very pleasure to introduce a well-known geriatrician at the European Geriatric Medicine Society. Professor Gaetan Gavazzi is co-leader of the special interest group on vaccine and infection diseases of the EuGMS, head of the clinics of geriatrics at the University Hospital of Grenoble-Alpes, and professor of geriatrics at the University of Grenoble-Alpes. He is a high-level research and with a great clinical experience in geriatrics and in infectious disease. And so he is the right person to present to us the day-to-day reality of infection management with a series of interactive clinical cases. Please, Gaetano.
Thank you, Alberto. Thank you, Thermo Fisher, to invite me. Thank you, Marco and Professor Gemellos, to present so beautiful data. We were in the cloud, in fact. Now we go back to day-to-day care. And perhaps it's quite different. We have a lot of recommendations for everything. I have, it's my disclosure. And before beginning with this clinical case, you will see after a QR code that you can scan to answer to the question. It will arrive after. Perhaps don't use the Wi-Fi, but much more your 4G. It's better, and you will have unless 1 minute to answer to the complex question. But it's live. So we are in front of the first clinical case. We will have three. It's a bit roughly, but you will see it's something happens every day. So it's a man, 87 years old, Basel characteristic, living in a nursing home for 2 years. He has an Alzheimer's disease, of course, prostatic cancer. So a lot of symptoms. Still several UTI, but we don't know which kind of. And in the anamnesis, we know that there is a recent modification of humor, of behavior, and sometimes aggressivity. The urine, the nurse said the urine is smelling bad now, he had no fever. Clinical examination is quite soft. There is only soft delirium, and there is no signs of severity. Of course, before you arrived, the dipstics have been done, and it's positive for nitrite and leukocyte, and urine culture is begun with leukocyte at the first examination. So the question is, what would you do? No treatment waiting for a urine culture exam, no treatment perform blood exam, CRP, leukocyte, what else? Give empirical antibiotic therapy, ceftriaxone 1 gram IV, give or amoxicillin. This is perhaps in between what happened in your country. So please use the QR code, and I invite you to participate. And I have to do also, I don't know at all what I did. I know it's quite difficult, but not at all. Perhaps after it's ready. You will say to me? Is it finished? Nearly? Everybody answer? So normally I have to see the stat. No, I don't see the stat. Yes. So the answer are there. So and I think the two both first is quite true, and few people said no treatment waiting only for urine culture exam. No treatment perform blood exam, CRP, protein, leukocytes, and few, but nearly 25% of people give antibiotics. Perhaps the question is the problem, and it's the title of the session, atypical presentation leads to over-treatment in frequent infection or infrequent things that seems or look like infection. Perhaps we need to ask about the signs and symptoms, of course. You know all this, of course, but perhaps the term acute is not inside. This person have a prostatic cancer, so he will have all these signs. I don't want to complicate too much, but it's chronic for a long time. And the signs, symptoms of clinical severity, of course. All these kind of things may help to perform over-exploration, treat or not to treat. And for the beginning, it was, of course, not to treat. You received the urine culture, and you are lucky. You are lucky. It's a coli, and E. coli was sensitive to every kind of antibiotics. So you will have the choice. You receive a blood exams, and here see that the creatinine clearance, of course, it was a question of Alberto, 80 milliliter per minute and per met square, and the CRP is 178 milligram per liter, and leukocyte 2 giga per liter, and procalcitonin has been done. I don't know if it's useful or not, but 0.1 nanogram per milliliter. So, the next question is, what would you do? No treatment waiting for clinical evolution. No treatment looking for reason for inflammatory syndrome. No treatment looking for CT scan or renal ultrasound. Give antibiotics, of course, ceftriaxone, and here no empirical. I'm sorry, it's not any more empirical. It's for amoxicillin, and I let you 1 minute to answer. The question is a bit more difficult. And it's frequent things. An inflammatory syndrome, very high, in people who are soft delirium in nursing home. With all this kind. Okay, I think it's finished. So here, the question is more than 1 out of 3, 36% will make a CT scan, give antibiotics, whatever, ceftriaxone or amoxicillin. 50% give no treatment, and no treatment looking for over reason. The two are there. The question is, perhaps if we need or not. I don't know what make the difference, but I can answer very fast because of the idea of the UTI and the PCT. We have several data that say that with a cutoff of 0.225 nanogram per milliliters, you have a very good predictive negative value to say that there is no urinary tract infection. This is very comfortable, and as you saw before, with the 0.1 nanogram per milliliter, whatever the CRP, you can not give antibiotics and wait, or looking for something else because to have such inflammatory syndrome, it happens something, of course. But if you look at this study, was been in the Netherlands in nursing home, specifically using a palliative of care, PCT and CRP, they try to analyze the negative and positive predictive value of CRP and PCT to diagnose UTI in nursing home. So said, but what is the UTI? The UTI was at least 2 urinary non-specific symptoms, urinal dipstick positive, urine culture positive, and no more 2 uropathogens, and symptoms resolved after antibiotic treatment. So it means that in the definition you put the antibiotics, which is quite difficult. But what they saw that there is absolutely no interest, either PCT, either CRP. But at the end they said it's not contributing, but in nursing home, possibly because these cases are mainly relatively mild infection of the lower urinary tract without systematic infection, systemic. And diagnosis of UTI is difficult, but perhaps the final real question is, do these residents need antibiotics? Not to have infection. You have all infection during the last 12 months and you didn't take any antibiotics, sinusitis, pharyngitis, and perhaps when you have a colonization, 50% of old women in nursing home have asymptomatic bacteriuria, meaning that each time you will have fever or something, you take a urine culture, it's positive. So the question is, we cannot use, perhaps we have no gold standard of UTI, and it was the problem of all this retrospective study, and Professor Gemaleros said, we need interventional study. It's why we have no real definition. So to compare the usefulness of PCT or CRP in front of an infection that we cannot say if there is an infection or not, each time we lose time and paper. So the first take-home message would be, atypical presentation are frequent but less than typical presentation. Please, 50, 60, 70% of people who have an infection have fever, even when you are old, even when you are 100 years old. So don't think that atypical is typical for elderly. It's completely wrong. Inflammatory syndrome is frequent without any infection. If you put all the inflammatory syndrome of your hospital with all people above 75 years, the main responsible will not be infection, but pulmonary embolism. In orthopedic surgery, the hip fracture, at emergency department, viruses, etc., etc. Bacterial colonization are more frequent, and it's still difficult not to treat when you are hurry, when you are busy, when you have not a lot of time to examine your patient. But the question will be, is there any emergency to treat? And it's what we will say. So procalcitonin may help not to treat, but there are so many controversial data that for elderly, I'm not sure that it's a first systematic tool that we need. But with this clinical case, we will see something else. Woman, 90 years old, living at home, admitted to the ED, disability, hypertension, cardiac insufficiency. The history is 2 days of fever. Wow, we are lucky. But no outbreak around, no specific contact with other people, asthenia and loss of appetite, abdominal pain, and no diarrhea. Initial clinical severity was like you see. There was fever, 38.4 degrees, pulse rate 90. Respiratory rate is high, 25, but oxygen saturation is quite well. There is no delirium, no meningitis syndrome. Clinical examination, very poor. No evidence for infection site. Any site of infection. The abdominal pain is located in hypogastric, near gastrum. The CT scan has been done in ED, you are lucky, thorax, abdominal, and pelvic. That's my fellow. One in ED, they perform a CT scan before to see patient with proBNP, troponin, and CRP. And after, they are going to see the... And we are lucky, perhaps not, no source of infection in the CT scan. Blood exam is CRP 160, neutrophil count, thrombocytes are normal, and hemoglobin is 140. So what would you do? No treatment waiting for clinical evolution at home. It's what we do now in France because you have no bed anymore for anything, for anybody. So all people are going back to home. I am present. No treatment looking for over-explanation. Antibiotic therapy. No treatment looking for procalcitonin level. And antibiotic with amoxicillin. You see, I like these two antibiotics. So you're ready? I need. I have still not the percentage. It's a bit more difficult, but I think we can see. So, it's interesting, but nearly 74 of you say that no treatment looking for procalcitonin level, but perhaps they put the two, no treatment and looking for over-exam because half, 25% say yes to this. 25% put the people at home. I think we can discuss. And it's true. But I will give you some data. The question is here that you have somebody who has the disease and potentially an acute infection. The question is like for UTI. UTI is not so important. You can live with a UTI, and UTI without any bacteremia, you have a very, very good prognosis. You treat just to shorten the duration of the symptoms for most of the things. But when you have a bacteremia, it's quite a different way of thinking. And the question is, do we have any symptoms? Do we have any biomarkers or morphological exam to decrease the risk of bacteremia? The most simple thing is to give antibiotics. Wait, as in nursing home for the Netherlands, in Netherlands, you give antibiotics and people, whatever they have, nothing, viruses, they will go better. And after you said, I was sure that they need antibiotics. But that's not true. And here we see that when you test PCT but not CRP, in this retrospective analysis at emergency department with UTI, with bacteremia and without bacteremia, you see that the PCT level up over 0.5 is associated with the presence of bacteremia. This means that the negative predictive value has to be determined to see if it's useful to use PCT as D-dimers in pulmonary embolisms. And we have this data for several years. It's only in adults here, showing that PCT may help to rule out bacteremia with a negative predictive value of 95%. But we have few data for only in elderly patients, so we perform the study, the same study in France, but not only from bacteremia, only from UTI, but also from primary bacteremia and also bacteremia associated with pneumonia or cholecystitis. And what you look there, it's around 120 positive blood culture between 2011 and 2016, and we look at the PCT and CRP, which was with the blood samples measuring PCT and CRP within the 24 hours of the blood culture. And what we found is that with a threshold of 0.5 nanogram per milliliters, we show the same thing that in younger population, with a very beautiful negative predictive value of 94%, meaning that if the PCT is under 0.5, you have 94% chance that there is no bacteremia. Meaning that if you have no clinical severity signs and you are not sure, but with a big inflammatory syndrome, of course, because it's this. When you have a big inflammatory syndrome, people are afraid and say it happened something, and it's not so wrong. It happened something, but it's an infection or bacterial infection, we don't know. And with the PCT, you can say that there is no bacteremia, as D-dimer is used for pulmonary embolism. So it could be used like that. Clinical case, the third case, and perhaps it will bring you something, reminds you from the presentation of Professor Gemarelos. Here the same, it's an unlucky woman because some month after, the woman, home care, 90 years, disability, hypertension, etc. Anamnesis is very beautiful, as you can see there, a very beautiful pneumonia, lobe, inferior lobe, the left one, at the CT scan and also at the radiograph. And she is treated by amoxicillin clavulanate for 4 days. The initial clinical severity was a fine score 120, curve 65.4, blood pressure today is a very good respiratory rate, pulse rate, blood pressure is normal. And the initial blood exam was like that, with a need in oxygen therapy, which she took it for 2 days, and at the beginning there was a very good C-reactive protein, 230. So the question is, what would you? So after Professor Gemarelos, you will answer well, but perhaps not. Really, what you do usually? Stop treatment without anything else, treatment for 7 days anyway, or treatment for 10 days because she is a high-risk person, very old, a blood sample CRP before stopping antibiotic, or blood sample Procalcitonin before stopping antibiotics. Here you have only 15 seconds. The last one. If you have question, you can stop me if you are not agree. If you disagree, there is no problem. It's good. Yeah. Thank you, Professor Gemarelos. So 65% of the population here will take procalcitonin, but 25% will get CRP, and I will give, and meaning that you don't use it's our recommendation, it's 7 days for pneumonia or 10 days when people are at risk, meaning that you don't individualize the duration of antibiotic therapy. And this is the right question. And of course, there was until last year no data really on the very old population to stop antibiotics, and performed with Philip Schwitz a very beautiful meta-analysis from the 28 randomized control trial. But as you see, in emergency department, in community, and in ICU. And when you look, there's more than 9,000 patients over 65 years old who are included in this meta-analysis. What they show that whatever the age, you decrease the number of days of 2 days, meaning that you decrease the kilogram of antibiotic that each people receive. And think about what Professor Gemaros and Professor Falcone said about the microorganism and microbiota, and not only, and effectively not only gut microbiota. What about mortality? Here we have not an impressive effect of decreased mortality, but at least it's the same, that it doesn't harm. And finally, I will present you our own multi-center study we performed several years ago, which isn't submitted now. People more than 80 years receiving antibiotic less than 30 days from 6 centers, and we perform serial PCT at day 0, day 2, day 4, day 6, day 8, and after discharge, at discharge. What you look is that here you decrease the number of days until 8 days in front of 10 days in the control group. It's a very few number of patients because it's 51 and 57 in each group. But at the end, when you look at the per protocol analysis, it's safe because we have a good outcome with few mortality. The PCT was 7.2 days and the control group was 10 days. But more important, I think, it's how we can individualize the duration of antibiotic therapy, meaning that more than 50% receive less than 6 days. It means that 4 days you can decrease half of the people receiving antibiotics. The problem is the algorithm adherence. It was 4 years ago, and it's 52. If I look at the result here now, that 65% of population here will use this algorithm now, I'm quite endless. So my take-home message are there. Procalcitonin usefulness in specific geriatric population. The question is the diagnostic. What do we want to treat? Are acute symptoms out there? The use of PCT are variable and with variable performance, so you have to use it with caution. How to wait? And the question is the prognostic. You are in front of people who have a big inflammatory syndrome with clinical signs of something but without any infection site. You have no severity signs. You can rule out the bacteremia, but it needs to be confirmed, and I can explain further why. And when to stop this, a very good evidence now. It's sure we need to use PCT to stop antibiotics, but the question is now, need to implement. We just finished in my ward a study. I am at the end of this ward, and still 30% of population didn't use the PCT for pneumonia and UTI. Thank you for your attention.
Thank you very much, Professor Gavazzi. Unfortunately, we have no time for a discussion, if only from the audience. Is there one short question? Or no?
I can answer
I-
there.
In any case, I received a comment and a question by one colleague. He can interact directly with Professor Gavazzi on the case number 2.
Okay, no problem. I'm there.
Thank you to everybody. Now we need to move to the keynote lecture in the auditorium. So, and on vaccine. So, thank you to everybody for coming to this last lunch session, and thank you for supporting to Thermo Fisher to support this lunch session.